para que no se nos atrasen los tiempos del Congreso. En primer lugar, vamos a escuchar al doctor Peter Barnes, maestro de muchos colegas en el mundo, quien no necesita presentación. Trabaja en Londres, en el Hospital Brompton y en el Royal Imperial College. Nos va a hablar sobre avances en el tratamiento de la EPOC. Good morning, Peter.
Thank you very much. Good morning, ladies and gentlemen. And I'd like to start by thanking Alat for the kind invitation to participate in this meeting in Medellin. So I've been asked to talk about advances in the management of COPD, which is an enormous topic because it includes many advances in the way that we treat patients and diagnose them and understand the disease. But I've decided to restrict this to advances in the drug management of COPD. If you look at the pathology of COPD, you can see that there's a marked abnormality of small airways and parenchyma, as shown in the right. So the airways are narrowed and thickened, and this is a consequence of inflammation that leads to fibrosis or scarring of these airways. This, of course, is completely irreversible. And in addition, you have destruction of the alveolar attachments from emphysema, which is completely irreversible. So you would conclude that this disease is totally untreatable. But in fact, there are things that can be improved by drug therapy. And this is shown here schematically. When normal people breathe out, the airways narrow, but they don't close because the alveolar attachments contain elastin fibers that prevent this closure. So alveolar air can be expelled from the lungs. But in COPD, as a result of chronic inflammation, you can see this pathological change with the narrowing of small airways and loss of alveolar attachments, which means that on expiration the airways may close completely, and this traps air in the alveoli. This air trapping can be measured by increased lung volumes and gets worse on exercise, which is known as dynamic hyperinflation, leading to shortness of breath on exertion and reduced exercise tolerance that are the major symptoms of COPD patients. But this is something that can be relieved by long-acting bronchodilators, and we know that these work by relaxing small airways, and therefore this allows alveolar gas that is trapped to be released, and this leads to improved symptoms. And the choices that we have are long-acting muscarinic antagonists like tiotropium bromide and more recently glycopyrronium and aclidinium, or long-acting beta agonists such as salmeterol and formoterol, which have been available for a long time, and more recently indicaterol. And the basis of this bronchodilator effect is shown in this slide. So in normal people, there is a certain degree of cholinergic tone, which is the tonic release of acetylcholine from cholinergic nerve endings, which lead to a small degree of bronchoconstriction. In COPD, you have this irreversible narrowing of small airways. So if you superimpose cholinergic tone, you get a big further increase in resistance, because resistance is proportional to the inverse of the fourth power of the radius. So when airways are narrowed, this gives a marked amplification of the effect of cholinergic tone on airway resistance. This cholinergic tone is blocked with anticholinergics, and this can lead to bronchodilation in normal people, although this has a very small effect on resistance. But in COPD patients, because of this geometric relationship, you can have a marked reduction in resistance. In COPD, it's clear that beta-2 agonists have exactly the same or equivalent bronchodilator effect to anticholinergics. And this is completely different from the situation in asthma, where you have many bronchoconstrictor mechanisms in addition to cholinergic tone. And in particular, you have several bronchoconstrictor mediators released from mast cells, such as histamine, leukotrienes, and prostaglandins. And these are contributing more to bronchoconstriction than to anticholinergics. The important pharmacological characteristic of beta-2 agonists is that they're functional antagonists, which means they counteract every known bronchoconstriction. And so beta agonists are by far the most effective bronchodilators in asthma because they counteract all of the bronchoconstrictor mechanisms. But in COPD, because they have equivalent effects to anticholinergics, we can conclude that cholinergic tone is the only reversible mechanism in this disease, in marked contrast to asthma. So the only treatable component of COPD is cholinergic tone, which can be treated equally well with anticholinergics and beta-2 agonists. So the introduction of tiotropium bromide was an important advance in the management of COPD because this is a much more effective treatment than short-acting anticholinergics like ipratropium. And the reason is that it gives sustained bronchodilation over 24 hours, whereas ipratropium wears off before the next dose is given. And so this gives a significantly greater effect of tiotropium than ipratropium, and this translates into a much better reduction in shortness of breath and improvement in the quality of life. But in this first study of tiotropium over 1 year of therapy, it was discovered quite unexpectedly that tiotropium also reduced exacerbations. This was unexpected because it was thought to reduce exacerbations you needed to have some sort of anti-inflammatory effect. And so this was a surprising observation, which was subsequently confirmed in a specific study where the primary outcome measure was exacerbations, confirming that tiotropium significantly reduces exacerbations, and by doing so, reduces the costs of health care of COPD patients by reducing hospital admissions, unscheduled visits to doctors, and the use of antibiotics. Therefore, tiotropium, although it's more expensive than ipratropium, is actually cheaper because you save the costs by reducing hospitalization. So we now have other LAMA. Glycopyrronium, which is actually an old drug, is having a similar sort of profile of effect to tiotropium. It has the same efficacy and duration. So these drugs are exactly interchangeable. Now, it was not certain whether LAMA or LABA were better, although in most studies they came out about the same. But in fact, most studies, many of which were unpublished, showed that tiotropium had some advantage over salmeterol and formoterol. So this was tested in a very large study comparing tiotropium once a day with salmeterol twice a day, and in around 7,000 patients, you can see that there is a significantly greater effect of tiotropium than salmeterol in terms of reducing exacerbations, particularly in the reduction of severe exacerbations, which of course are the most important events for the patient. But now we have a once daily beta agonist indacaterol available, and you can see that this is better than salmeterol twice daily. So you get a better reduction in symptoms, a better effect on FEV1, and this translates to a better effect on the quality of life. And I think what this is telling us is that if you think about bronchodilators in COPD, once a day is better than twice a day, which is better than 4 times a day, and this is irrespective of the class. So the important thing is duration of action. And the thing that is best for the patient is sustained bronchodilation. So here's tiotropium, which gives sustained bronchodilation over 24 hours. And you can see that formoterol is wearing off between the doses. So it goes back to baseline before the second dose of the day. But surprisingly, these drugs have additive effects. So you see a greater peak and a greater area under the curve. So giving these drugs together is advantageous, but this is not convenient because you have to give formoterol twice a day and tiotropium once a day, and it would be much better to have 2 once-a-day drugs. And in fact, it's been shown that indacaterol and tiotropium have additive effects. This is a very important study looking at indacaterol and glycopyrronium. The maximum recommended dose is 300 micrograms per day. And the reason why this is the maximum dose is that if you increase the dose further, you get side effects which are long-acting. But in this study, they did increase the dose to 600 micrograms, and you can see that you get no further bronchodilation. So in other words, 300 micrograms has reached the top of the dose response. And since beta agonists counteract every known bronchoconstrictor mechanism, including cholinergic tone, you should expect no additional bronchodilation on top of the maximum effect of a beta agonist. And yet, when you add glycopyrronium, this is actually the combination inhaler QVA149, you can see that there is a doubling of the bronchodilator effect, giving a peak bronchodilation of over 300 mils, which is the biggest bronchodilator effect that has ever been seen in COPD patients. So this is something that is not understood and is unexpected, but nevertheless is lucky for the patient. And we don't know exactly the mechanism for this additive effect, but we think it's related to crosstalk between the cholinergic and adrenergic pathways. So acetylcholine stimulates M3 receptors, M3 muscarinic receptors, which are coupled to an enzyme, phospholipase C beta, which generates IP3, which is the second messenger of M3 receptors, leading to calcium release and bronchoconstriction. But it also generates another mediator called diacylglycerol. Long-acting beta agonists activate beta-2 receptors through the coupling protein GS to adenylyl cyclase, which increases cyclic AMP, leading to bronchodilation. And what we showed many years ago is that diacylglycerol activates an enzyme, protein kinase C, which is in the cell membrane of airway smooth muscle cells. And this phosphorylates the beta-2 receptor NGS, which uncouples the receptor from adenylyl cyclase, reducing the bronchodilator response to beta agonists. So when you give a LAMA, you're blocking the cholinergic pathway, which reduces the generation of diacylglycerol, and this then reduces the stimulation of PKC, which leads to recoupling of the beta-2 receptor and enhances bronchodilation. So in other words, the cholinergic tone is a braking mechanism on beta agonists, and by blocking it, you can enhance the effect of beta agonists, which may account for this additive bronchodilation. And this is reflected in long-term studies where you can see glycopyrrolate is equivalent to tiotropium, as I already showed, and also equivalent to indacaterol, because these are all once-a-day drugs. but adding indacaterol and glycopyrrolate gives you this increased bronchodilator effect. And so this is leading to several companies to develop combination inhalers that are working once a day. So QVA149 or Ultibro is now approved. Olodaterol and tiotropium is in development, and vilanterol, a new meclidinium known as Anoro, is also approved. There are also twice-daily combinations that use formoterol as the LABA. These are less satisfactory because they have to be given twice a day, which is less convenient for patients. And then you have other treatments based on this principle. MABAs are dual function molecules that have a LABA and a LAMA, which are linked. And these are very difficult drugs because it's very difficult, if not impossible, to balance the LABA and the LAMA effects. So this GSK drug, for example, is a beta agonist, whereas the AZD drug is an anticholinergic. The ultimate treatment for COPD is the triple, which contains a LABA, a LAMA, and a steroid. And one of these is already developed, the Triahale, and another one is in advanced clinical development. These are not very useful inhalers because most people with COPD don't need a steroid, and most people with asthma don't need an anticholinergic. So when we give long-acting bronchodilators, we're reducing air trapping, which reduces symptoms, but unexpectedly we also reduce exacerbations. And we think this is because of stabilization of the airways, and that this may lead to reduced disease progression and reduced mortality. The reduction in exacerbations cannot be explained by any anti-inflammatory effect because long-acting bronchodilators don't reduce any indices of inflammation in COPD. But this airway stabilization is very important for improving symptoms and reducing exacerbations, but may have an unexpected benefit in reducing airway compression and mechanical forces that may reduce fibrosis that could be a mechanism where you could reduce disease progression. So if we compare tiotropium and salmeterol fluticasone or seretide, we don't see any difference in reduction of exacerbations. Incidentally, these two drugs account for more than 75% of all the money that is made in COPD drugs. So these are the biggest drugs in the world for COPD treatment, and it looks like they're equivalent. But the steroid component is probably unnecessary, and in the TORCH study, as you all know, seretide did reduce mortality, but this was not quite significant, whereas the steroid, if anything, was increasing mortality. And if you put all the studies together, more than 16,000 patients show no effect of steroids on mortality or disease progression. But the problem is that these treatments can lead to adverse effects, and these long-term studies demonstrated that inhaled steroids lead to pneumonias in COPD. And if you look at the TORCH study, for example, Sami Suisa has calculated that the number of patients needed to treat to prevent one exacerbation is 44. The numbers needed to treat to induce one episode of pneumonia is only 16. So there's a clear disadvantage to using steroids. And this is confirmed in a large population study demonstrating that in patients treated with inhaled steroids, there's a significant increase in pneumonia, which is dose-related, and fluticasone propionate is more likely to cause pneumonia than budesonide, which was confirmed in another observational study showing that there was a greater death rate from seretide than Symbicort. So inhaled steroids in COPD are only indicated probably in the patients who have asthma COPD overlap syndrome because they treat the asthma, possibly infrequent exacerbators, although this is dubious. We should avoid high doses. Budesonide is safer than fluticasone, and we need new anti-inflammatory treatments. And the last study that I'm going to show is the study with roflumilast, a phosphodiesterase 4 inhibitor, which significantly improved lung function, but the improvement is actually small. It's around 50 mils, which is clinically insignificant, but there is a small reduction in exacerbations. So the problem with roflumilast is that although it may have anti-inflammatory effects, there's no effect on symptoms or quality of life. There's a large number of dropouts in all the studies showing the side effects of roflumilast, and these are diarrhea, nausea, headaches. The patients don't like this treatment, and so it has very little impact, although it could be an add-on therapy in patients with severe COPD and chronic bronchitis who seem to show a better response, and probably it's better than inhaled steroids, which don't do anything for inflammation. So once daily bronchodilators are the most effective current treatments that we have, and the additive effects of LABA and LAMA mean this is the maximum bronchodilator response we can get. Inhaled LABA, ICS-LABA combinations are only suitable for selected patients, and the side effects of inhaled steroids are a problem. We need anti-inflammatory therapies for the future, and although roflumilast is anti-inflammatory, it has a very poor efficacy as the side effects are dose limiting, and it limits the dose you can give. So what we need for the future is effective and safe anti-inflammatory therapies, and these would then be applied much earlier in the course of the disease to prevent its progression. Thank you for your attention.